All right, everyone, welcome back to another episode of Forward Physio. Today, I feel very, very lucky to be sitting with Jared Powell. Jared is a clinician and a researcher, but on, at least for me, the more important side, someone who has had honestly a profound impact on how I think and operate as a clinician. Someone who I've been following for a long time, whether that's on Instagram, where you might know him as the Shoulder Physio, on his podcast, or by reading his research. Jared, I perceive you as someone who, in the midst of our very chaotic and polarizing profession, is often a voice of reason and someone who helps sort of guide the boat a little bit into a better future. So I'm really, really excited to chat with you. So thanks for coming on. Just to get things kicked off, would you mind telling us a little bit about yourself from a professional standpoint?
Thanks, Noah. It's a real thrill to be here, mate. Nice to meet you and talk to you. We've been interacting for some time on social media, but it's good to chat. So a bit about me, physio by background, 15 years into it. I've been doing my PhD for the last 6 or 7 years, and I'm just about to hand that in the next few months, and that's very exciting. It's been a long time coming, and it's been a huge trauma, but it's going to be hopefully worthwhile. And yeah, I've taken a little bit of a break from being a clinician over the last few months to try and get this thesis done. But I do run a telehealth company where I see people with various complex shoulder pain pathologies and presentations that have been refractory to treatment. And yeah, that's a really important part of my job and my philosophy. I really feel like that's something I want to keep doing going forward, even when research sort of becomes a little bit more demanding. Research is always trying to creep in and take up more time, but I still want to be a clinician. And that's me. I'm married. I've got 2 kids, 2 boys who are psycho in the best possible way. And what do? I love sport. I'm just getting more and more into running. I've been like a lifter and a surfer predominantly in my life, but in the last few months, I've really started to get into running. It's like a midlife crisis thing. I think you either start golf or you start running or you start smoking meats or brewing your own beer or something. So I've started running and that's been really fun. And I'm excited to see where that takes me over the next few years.
You ask everyone on your podcast, what do they like to do for fun? And I was about to ask you that, but you sort of beat me to it. So I'm glad you got to share a little bit about yourself. At one point there, you mentioned that, being a clinician is an important part of your philosophy. And that sort of made me think that you're often talking about philosophy and history as well, whether it's like Karl Popper or how certain ideas in physiotherapy have come into fruition. How important has that been for you as a clinician and a researcher, just having this sort of background interest in philosophy and history?
Honestly, it's fundamental. A lot of my thinking now isn't directly related to physiotherapy. It's more in relation to ideas of philosophy, particularly philosophy of science, and epistemology, how we come to know things. And then I take those ideas, which have been around for centuries, and then apply it to current physiotherapy practice. And it really gets my juices flowing. That's probably a weird turn of phrase, but it's fascinating for me because I can pick up Popper's book from the 1930s, and it's still just as relevant to a lot of ideas and problems that we're having in physiotherapy at the moment. And a big part of my thesis is actually going to be incorporating a lot of that stuff. And it's sort of how I've come into, so my thesis and my work has been centered upon exercise for shoulder pain and how and why we think it works. And a lot of that and the philosophy of causality and the philosophy of science is really interesting topics. I don't know if you want to go too deep into that. But, we seem to think in physiotherapy that there's these like simple causes for a condition, say the onset of shoulder pain, and then exercise is a simple solution that works in a very simple biomechanical way, such as increasing subacromial space distance or improving strength or normalizing scapular movement or whatever it may be. We seem to think that exercise or any treatment, manual therapy as well, works by these very simple biomechanical mechanisms or mediators. And then when you actually go in and you look at the literature or you do some original work, we find out that they don't work by those mechanisms at all. They are plausible hypotheses for sure, but once we've sort of gone in and done some investigative work and looking at mechanisms, they haven't really borne out. So a lot of that interest in philosophy is the foundation for my thesis and for how I look at common things within the physio musculoskeletal space at the moment.
And this is what I was sort of referring to earlier when I said that you're helping to sort of guide the boat in the right direction. You're not just having these sorts of conversations all the time, but you're publishing research on something that I think is so important for us, which is like, how does exercise actually work? And what are these people's beliefs around exercise when it comes to shoulder pain, whether it's the clinician and you have research on that, or the patient, which you also have research on. I think these things are critical. And although you chat about this when it comes to shoulder pain, it's a little bit bigger than shoulder pain too, right? Because we could often apply these same sort of ideas to a lot of different conditions when it comes to, musculoskeletal pain, like low back pain, like knee osteoarthritis. I know you talk about a good amount too.
Yeah, 100%. I think when we're talking about non-traumatic musculoskeletal conditions, there is a huge overlap. If you draw a Venn diagram between all of the conditions, there's a huge overlap between a lot of it, actually, in terms of the onset of pathology, the onset of pain, and also how we focus on treating that condition. Interestingly, maybe slightly tangential, is that we've got a paper under review at the moment which looks at it's a long, complex thing that we're looking at, but one of the things that you can do in order to establish a causal claim in epidemiology is to look at whether what you do is you look at other conditions, right? So you look at we can look at exercise for knee pain. We can look at exercise for low back pain. We can look at exercise for shoulder pain. We can look at exercise for any single one of these conditions. And what we see is that it's all pretty similar in terms of how exercise is perceived to work. So for all of those conditions, it's predominantly perceived to work via biomechanical constructs. The effect sizes are pretty similar across the board. We kind of have these modest effect sizes where exercise is probably better than doing nothing, probably better than usual care, arguably no better than placebo, which is pretty shameful when you think about it.
Wait, it's not a panacea?
No, not at all. Far from it, in fact. And for some people, it can make them worse or certainly no different. Again, I caveat before anybody starts throwing shit at the screen or the phone or whatever. I love exercise. I prescribe exercise. It's my bias, so everybody chill. But it's certainly not a one size fits all, and it's not going to help everyone. And then for all of these conditions, we don't really know how exercise works. There's a little bit more research on knee osteoarthritis, hip osteoarthritis, and low back pain in terms of how it works. But we're really at the start of this research program. It's only been going on for 10 years max, whereas we've been doing clinical trials to test if it works, not how it works, but if it works for 30, 40 years, really since the advent of evidence-based medicine in the early 90s. So across all of these conditions, there is huge overlap between what we do and what we don't know. But we've got a ton of work to do over the coming years in order to actually figure out these mechanisms of how it works, particularly because there's something that I'm interested in, which is called evidence-based medicine plus. So not evidence-based medicine, but evidence-based medicine plus, which is like evidence-based medicine 2.0, where we're not just looking at evidence from randomized controlled trials and then their systematic reviews, and that's at the top of the evidence-based hierarchy. We need to be more concerned about mechanistic research. So evidence-based medicine plus, or evidence-based medicine 2.0, views evidence from RCTs and observational studies that look at really just finding a correlation between two different variables. But we also need to look at and think it's really, really important to find mechanistic evidence and to conduct mechanistic research to find that mediator or mechanism that explains the correlation. And so that's something we really haven't done in physio. We're obsessed with answering the question, does this work for this condition, and to what extent, like what's the magnitude of the effect? We've really neglected the second part of that question, is to find a valid mechanism that explains that correlation. And so I think that's where a lot of our stuff is falling down a little bit, because if we think of ourselves as a scientific profession, and part of science is to find explanations, and part of finding the key ingredient of finding an explanation is to find a mechanism or mechanisms that explain an outcome. So I don't know how I got into that, but so for me, that's going to be the key, or a really exciting space to watch over the next 20 years as we start to be more concerned with mechanisms. And that may improve our clinical outcomes. If we know how something actually works, we may know what to target rather than just fluffing around and throwing shit at a wall and hoping something sticks.
Right. I was just going to say that the reason this is so important, it's not just from a research standpoint and from, like the idea like, oh, it's cool to know how things work. Right now, in the current state of physiotherapy, we are constantly just throwing shit at the wall and seeing what works. When it comes to exercise or manual therapy and all of the different techniques that go into those two things. When it comes to education, like we know things may have a small or a modest effect size, but we often don't know why. And then therefore, we can't really determine what is the best dosage or what's the best type of exercise or the best type of manual therapy, unless we just keep on conducting research the way that we're doing and just try a bunch of different things, again, without a good reason for trying them, and just, again, seeing what works when it comes to dosage instead of just the type of treatment. So it's critical. And from a real world standpoint, we're at a point where in the clinic all the time, people are asking me why they're getting better or why exercise will help them. And I still struggle to answer that question. And sometimes with certain patients, I can be very honest about that. And it's always, sometimes it gets a little bit of a chuckle. We're in 2024 and we don't know.
Yeah, well, you should struggle with those conversations because we don't have the answers unless you fake it till you make it, which a lot of clinicians do. They just say it's getting you stronger. And this is why I've got a problem with this mantra and this slogan. I hate slogans in healthcare. Slogans are for politicians. They're not for scientists and healthcare workers. Is because they become instantiated into pop culture without people really critically appraising them. And then it takes fire. It takes hold. It catches fire. It starts to spread like a virus. And then all of a sudden everyone's saying all these slogans, but nobody's really addressing the veracity or accuracy of the slogan. And so like when we're having conversations about how things work in clinic, we have to acknowledge the uncertainty. But that doesn't mean, we sit around and we say, we have no idea, don't worry about it. You can still sell a person on something with uncertainty. You could say it could work by all of these great things, it could make you a bit stronger. It could reduce systemic inflammation. It might change the biochemical milieu of your shoulder complex. It may improve or enhance various psychological features, so on and so forth. So you can be uncertain, but it shouldn't prevent action. You can hypothesize, you can conjecture, you can have a really robust conversation with a patient and say it may do all of these things. But you could also just do nothing. You could let time take care of it. You could choose whatever treatment you want to choose, this is my bias. I'm uncertain about how it's going to work. But to be honest, we're uncertain about how paracetamol works in 2024. So I don't think
Hmm.
we need to be too ashamed of that we don't know how exercise works.
Hmm. So we're already getting really into uncertainties. Let's talk about what we can be certain about, or at least a little bit more certain about. Uh, the common model, at least historically speaking, for why shoulders hurt a lot of the time is because of impingement, or it's because of the shoulder blade moving funny, which we call scapular dyskinesia. What's wrong with these two models? Can we still be using them in 2024?
I'm going to assert no, because if we're a scientific profession, our theories need to be grounded in evidence, as a bare minimum. And so when we're talking about shoulder impingement, I think it's a very plausible explanation for the onset of rotator cuff tears and the onset of pain. It's certainly, I'm not going to hold anything against those who championed and came up with the hypothesis in the 1970s. But what happens is when we go and test that hypothesis and those results basically refute the explanation or the hypothesis, then as proper scientists, we need to change our beliefs when confronted with conflicting evidence. And that's really what's happened over the last 20 years. We really haven't had any evidence to verify this theory of shoulder impingement. We've had volumes of data that really challenges it, from most people will impinge their shoulder. We're talking about subacromial impingement here. Most people will have subacromial impingement when they raise their arm into the air. Certainly 100% of people will have internal impingement, which is different to subacromial impingement, when they elevate their arm into the air. However, we don't know, we can't really pick as to who will have pain and who won't have pain out of those people who will impinge. Obviously, with subacromial impingement, we've got placebo-controlled trials now where we actually have people go in for a surgical subacromial decompression no better than someone who has a fake surgery. So that's, level one evidence against the theory. Even in that placebo-controlled surgical trial, people who had no treatment also improved pretty well over time, almost as much as the people who had sham or actual surgery. So time is still a pretty good healer with people with subacromial impingement where nothing is actually changing. We're not optimizing the subacromial space. We're not changing the acromion. Things are just settling down for whatever reason. Talking about natural history is a thing we can perhaps come back to.
Yeah.
Tons of other issues with shoulder impingement. We've got qualitative work which says that when people are given the diagnosis of shoulder impingement, it makes them fearful. It makes them have these overriding biomechanical beliefs of a bone sticking into a tendon and causing fraying and friction and tearing on the structure, which is a pretty horrible thought when you're a lay person trying to lift your arm into the air. If that's what you're imagining what's going on inside your shoulder, certainly doesn't accentuate or promote exercise as a primary treatment. And then scapular dyskinesis, it's got issues with reliability. It's got issues with validity in terms of detecting it. And then, we might be able to, if we can detect it magically, which we can't in clinic, but if we do have some, 3D biomechanical measuring device in our clinic for whatever reason, then we may be able to detect it. But then, do we change it with our interventions? No, we don't. We can't really change scapular dyskinesis, and we don't need to, because people's pain will decrease, people's function will improve, and their scapular dyskinesis may remain. So, what's the real point of it if we can't detect it accurately and we don't really need to change it in order to help someone's pain? So there's a quick spiel on those two things.
If, with most people, it doesn't need to go away. Do you think it's ever the case that you do need to address it? Is it ever important?
For rotator cuff related shoulder pain, I would
Yeah.
say very rarely it will be something that needs addressing. If it's like profound and you think it's like long thoracic nerve palsy and it's really affecting the proper stability of the scapula, then perhaps, but then if it's a long thoracic nerve palsy, what are you going to do? You're not going to do manual therapy or exercise to try and get it better anyway. You're probably going to send that person to a doctor or to have some sort of expert opinion on it to figure out why it's happening, and it will probably just get better over time. And sure, you could do some exercises to facilitate rehabilitation. For shoulder instability, there's some data that people with multidirectional shoulder instability may have a scapular dyskinesis that is affecting the stability of their shoulder. And certainly in those cases, I am a little bit more amenable to addressing the scapula and trying to improve, stability is the wrong word, but its ability to function in concert with the shoulder a little bit more. But that's a totally different kettle of fish. But certainly for people with rotator cuff related shoulder pain, subacromial pain, which is 8 out of 10 people that we see with shoulder pain, I don't think it's anything that we need to even assess and certainly not treat. Now that could be a controversial statement. So when I say assess, I don't think you need to turn the person around, get your slow motion video camera out and try to detect subtle differences between the symptomatic and asymptomatic side, and get the magnifying glass out and look at the timing of it. Honestly, I'll spin the person around. I'll say, yep, do a few of these scaption raises with a couple of kilo weights in your arm, just to give the impression and the ceremony that I'm a detective looking for a pathology or an issue in their shoulder. I really don't pay it too much attention in terms of my treatment and my treatment planning and my diagnostic workup at all.
Yeah. When I was in physio school, when we were looking at how to assess the shoulder, when it comes to our objective tests, we would look at the posture of the shoulder and we would look at the way that the scapula, the shoulder blade was moving as someone would raise their arm overhead. And that wasn't very long ago. And at the time I was a little bit skeptical of it. And to give my schooling credit, they would say, we're going to take a look at this, but it may not matter. And for me, the thing that I was always confused about at the time was, well, when does this matter? And we didn't seem to get many clear answers on that. And I think I'm at the point now where I practice in a similar way, where I will probably look at them raising their arms overhead, but I am rarely looking at their posture and how the shoulder blade is moving. So personally, I don't find that controversial.
Yeah, nice, good. You shouldn't. It should be. It's evidence-based to hold these views. However, the zeitgeist of physiotherapy and social media physiotherapy with some of those big channels, Move You and all that, they still very much promote and promulgate these theories, which are systematically disproven when you look at the evidence.
You've tried to set up a debate with them, haven't you?
I have, yeah, and yeah. Look, they've got no interest in coming on and having hard conversations, which is fair enough. Like, why would you? They've got a captive audience. They're not incentivized to learn anything. It's a business, right, which is fine. Just coming back to the scapular dyskinesis for a moment. There's a theory that you can do a scapular assistance test, which is you may recognize or identify scapular dyskinesis, and then you can do a scapular assistance test to promote upward rotation of that scapula. And if that test is positive, then there's an assumption that a scapular dyskinesis may be of concern if a scapular assistance test can help that individual's symptoms. Then you have to think that, why is it that a scapular assistance test may be helping someone with the shoulder pain? Is it correcting the actual movement of their scapulae, or is it just making the movement easier? You're just taking away some load from some sensitive structures within the shoulder by literally helping the shoulder up. It's like having knee pain and then doing a squat in a swimming pool. It's much easier versus if you do a squat on land, right? There's just less load going through the joint. I think it's the exact same thing with a positive scapular assistance test. So I think we can get a lot of like false positives with these symptom modification procedures, where if we get if we get a helpful response with a scapular assistance test, it doesn't mean that the scapula is the issue. I think it means that we're just taking a little bit of load off some sensitive structures or the sensitive nervous system or sensitive human, and that's okay. We can still incorporate that into our program or whatever, but I think we still need to be mindful that there may be other explanations other than a scapular dyskinesis for that positive scapular assistance test.
Yeah. I think it's not necessarily an issue with the test, but the narrative around it. And I want to ask you a little bit more about special tests. But when I do the scapular assistance test, I'm never using it for a diagnostic standpoint. When I do it and it's positive, so it feels a little bit better when I give them some help, I'll usually use that to inform my exercise planning, or how I might sell exercise to them. Where maybe if they really, really struggle to lift their arm without pain, then I'll do that test. Oh, it's a little bit better. Maybe here's a way that you could do it at home. Here's a cane, hold in your other hand, and you can maybe help your arm up, similar to how I just did. Or, look, here it is where your shoulder feels a little bit better when we take away some of the load. I think over time, as your shoulder can maybe tolerate load a little bit better, it might feel a little bit better. So exercise is a great way to build that up. So from a special test standpoint, there's so many special tests when it comes to the shoulder. How do you think about those? And do you use them to inform your diagnosis, or do you not use them at all? Or do you use them and have you sort of reframed the narrative around them? Hey physios, I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are that Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it.
Yeah, so there's over 200 special tests for the shoulder now.
Whoa.
Which is a lot, and you've got to do them all, Noah. In clinic, you have to do every single one of them. No, so yeah, look. So my good friend and co-conspirator is Jeremy Lewis, and he's published a lot on special tests of the shoulder. And he's got a famous article with Paul Salam called "Is it time to put special tests for shoulder pain out to pasture?" which I'm sure you'll link in the show notes and people can go and read. Nice, easy editorial. In my experience, so I do telehealth now exclusively. And so I'm not really in there getting people to do their own Hawkins-Kennedy tests, Job's test, or any of these things, to be honest. I will check range of motion. I will maybe get them to do a resisted external rotation test. Against
how do you do that
hand.
online? Oh, okay.
Just say resist external rotation. How does it feel? And to be honest, Am I doing anything with the information that I get from that? Maybe, because I'm pretty so I guess we're going to talk about classification here a little bit. So the first thing I'm trying to do is I'm trying to ascertain, is it a stiff shoulder, is it an unstable shoulder, or is it a rotator cuffy related shoulder painy kind of presentation, or is there a sinister pathology that I need to be really wary of? And so once I've ruled out a stiff shoulder, which is easy to do, right? In my opinion, it's super easy to do. I don't know how people can miss a frozen shoulder diagnosis.
When you say stiff shoulder, do you specifically mean frozen shoulder?
Primarily, you can have glenohumeral joint osteoarthritis, you can have a lock dislocation, you can have malignancy, etc. But those things are exceedingly rare. It will mostly be a frozen shoulder or glenohumeral joint to a lesser degree, osteoarthritis. So yeah, it's primarily going to be frozen shoulder. And for that, you really just need to look at active range and passive range of motion, especially external rotation, internal, all the stuff you were taught at school about frozen shoulder is actually true. And there'll be a profound limitation of external rotation, internal rotation, abduction, and then flexion. And especially up at 90 degrees, and you get them to do an external rotation, passive range of motion movement there. So you get them to simply lie on their back and just let their arm in a supine position and try and let their arm go down with the help of gravity into external rotation. And there will be a profound limitation compared to the other side, where the other side will get to that 90-90 position and the affected side will be suffering and struggling. So ruling out a stiff shoulder, obviously you got to look at the person. They're usually between 40 and 65, predominantly female, so on and so forth, perhaps diabetic, metabolic factors going on, blah, 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 blah. Once I've ruled out frozen shoulder, which I can do in about 30 seconds to a minute, then unstable shoulder. Do you have a history of a dislocation? Pretty simple question to ask. Do you feel apprehensive when you get into certain positions? It's pretty simple to rule out an unstable shoulder. Some therapists love this concept of they've got this subtle instability of the shoulder joint that doesn't lead to dislocations, but it's this like multi-directional instability, which I think is a bit of a cop-out diagnosis, where you have to have an ultrasound and you look at the movement of the humeral head under an ultrasound. And I don't love it as a diagnosis, so I don't really go there. And then once I've ruled those things out, I'm not suspicious of red flags, then we're left with like rotator cuff related shoulder pain, which is an umbrella term. Some people hate rotator cuff related shoulder pain as a label. I don't care. There's no, we're not going to walk around and lift up a rock and there's a universal law that says this is what we should call somebody with non-traumatic shoulder pain. It's an opinion. It's going to be a conjecture. Jeremy Lewis has proposed rotator cuff related shoulder pain. Charles Neer proposed shoulder impingement syndrome. Others propose subacromial pain syndrome. Patients don't know what subacromial means. I always find that such a funny thing to say to somebody. It's this tenuous area of the body. But most patients or most people have heard of the rotator cuff, and it doesn't take much to explain that it's a muscle and tendon complex. It's not like this ethereal structure within the shoulder. So that's why I tend to use it. I'm actually okay with people using rotator cuff tendinopathy, or even if they have a partial thickness tear, I can say, you've got a partial thickness tear of your rotator cuff, and that may be contributing in some small way to your symptoms. But then you have to have the conversation about how relevant is to that, to clinical outcomes, so on and so forth. So
can we have that conversation in a little bit?
We can, for sure. But diagnosis is always going to be controversial, and it's mainly people who hate the term rotator cuff related shoulder pain have personal issues with the founder of the condition as opposed to the diagnostic label itself. As you're going to find in physiotherapy, there's lots of competition, there's lots of infighting, which frustrates the hell out of me. I think it was Alexi. I don't know how to pronounce his last name. Apologies.
Levier, I think.
Levier. No bullshit physio. He says he had a cool tweet that says maturing in physio is realizing that most of your physio rivals hate each other. And it's kind of true, unfortunately. It's a real shame because we all should be working together for a common cause to try and, extend knowledge and help people with shoulder pain. Anyway, what was up to? Okay, so once we think it's rotator cuff related shoulder pain, Do we need special tests to verify that diagnosis? I propose no. So what I'll do is I'll look at range of motion just because I've already done it to rule out a stiff shoulder anyway. So I'll incorporate that into my clinical reasoning and my diagnostic workup. I will sometimes do a resisted external rotation test to see if there's a profound, like full thickness tear that's causing pseudo paralysis of the shoulder. They will be really weak into external rotation, but I'm often doing like resisted strength test anyway with a dumbbell. So I'm like, get in side lying, do side lying external rotation. How many can you do? And a profound weakness will show up on that test anyway. I'm not doing a Hawkins-Kennedy test on people. I'm not doing an O'Brien's test. I'm not doing a Neer's test. I'm not doing any of those things. Most people, when you do an abduction test, will have a painful arc, which is fine. That's not indicative of subacromial impingement. It's just indicative of having a sensitive rotator cuff bursal complex that often goes hand in hand with having rotator cuff related shoulder pain. So that's kind of the special test that I'll use. It's range of motion, it's resisted external rotation, and then I'm doing a lot of functional resisted training tests. And perhaps not tests, it's movement experiments or resisted movement experiments, which I detail significantly in a recent publication of mine, which Noah, you'll hopefully list in the show notes as well. It's called "Is Exercise the Right Treatment for Rotator Cuff Related Shoulder Pain?"
Mm-hmm. I think what I'll do, would it be sufficient if I just sort of linked the like PubMed searching your name into the bar, and then all of your things will come up, all of your publications will come up? Okay, so I'll do that. I think if anyone had questions about how you can practice online and properly assess someone's shoulder, I think that probably should have answered that question. But on that topic, is there anything that you would want to sort of cover about why you think online physio is feasible?
Well, the evidence suggests it's non-inferior to face-to-face care for every single condition we've looked at so far. So, yeah, I mean, my opinion pales into comparison compared to the evidence base that we have now. So, but in my experience, it works well. So I don't use manual therapy in my treatment. I don't care if you do, but I don't. So therefore, it wasn't really a consideration. Again, remember that I'm perceived to be a shoulder expert by patients. So they're coming to me and they're not really wanting me to massage their shoulder for half an hour or 45 minutes. They want me to give them a diagnosis and a treatment plan going forward. So they may have different expectations of me versus you versus the street corner physio that they might see. So just bear that in mind. But yeah, telehealth works really well for me. I have no issues in promoting physios that are listening to this to incorporate that into their practice for the appropriate patient. But again, it comes down to the patient. If they want to see a person in face-to-face, I will recommend that to them straight away.
Mm-hmm. Cool. So yeah, rotator cuff tears. What's the issue with using those to explain someone's pain? When do we need to worry about them? When do we not need to worry about them? How common are they? Let's dive into it.
Very common, become more common as we age. It's almost a rite of passage as we age, as we get into our 5th, 6th, 7th, 8th decades of life, that we're going to have a rotator cuff tear. Typically the cascade is tendinopathic change, partial thickness tear, increasing in size over time until we get a full thickness tear. Now, this is like a non-traumatic aging related process. I think, look, it's such a complex space, but the summary of the literature that we have is that rotator cuff tears, non-traumatic rotator cuff tears on their own are inconsistently painful. We can't really judge what somebody is experiencing when it comes to shoulder pain based on a rotator cuff tear alone. Now, having said that, as rotator cuff tears increase in size beyond about 2.5 centimeters, some people are more likely to have a correlation between shoulder pain and a larger tear. versus a partial thickness tear, for example, where we really have no idea if that partial thickness tear is going to be symptomatic or asymptomatic if we just look at someone's scan. Certainly, we've got a lot of high-functioning athletes out there who have full strength, full function, no pain, with partial thickness, even small full thickness tears in their shoulder. So we can't really say that that person's minute tear is affecting their function and causing their pain. However, as that tear starts to increase in size, we're eventually going to start to see deficits in strength. What relevance is that to somebody's pain experience? I'm not too sure. Probably not much, but that deficit may prick our ears or increase our suspicion that there is a rotator cuff there that we may want to look at or get scanned or imaged and then have a surgical opinion. And so what happens if we see someone with a small full thickness rotator cuff tear? Let's say it's 1 centimeter, which is the definition of a small full thickness rotator cuff tear. What are we going to do with this person? Well, the evidence says pretty categorically that in this individual, a non-surgical exercise-led treatment program over 12 weeks is just as effective as a rotator cuff repair surgery. And that's based on pretty good randomized control trials and systematic reviews that incorporate all those randomized control trial evidence. And that applies to traumatic onset rotator cuff tears and non-traumatic onset rotator cuff tears. Now, the group think and the dogmatic belief is that typically traumatic tears require surgical opinion, and I'm okay with a surgical opinion, but we do have data that suggests that those people do just as well with exercise versus surgery. So that's cool. You can tell that to a patient that they've got options. They can go down a surgical pathway, they can go down an exercise pathway based on their preferences and their values. Yeah, I don't know. I can't remember what else you asked, but there's a lot more we can go into. The thing with a rotator cuff repair, Noah, is that there is a perception, and I just did an Instagram post on this, that a rotator cuff repair is always effective in terms of restoring the integrity of that tendon, right? You fix the tear, and then it's fixed forever, and it's good to go. It's as good as new. 25% of the time, and some data says much more, up to 50%, that rotator cuff repair is going to fail. It's going to re-tear. And those people still have pretty good clinical outcomes. Most of the time, no worse than those who have an intact repair. And so you start to think, what is the actual mechanism of a rotator cuff repair if that repair is failing at a pretty high rate? And there's some work going on at the moment which is comparing a placebo cuff repair to an actual cuff repair to try and disentangle the mechanisms of rotator cuff repair surgery and how much of it is placebo and expectation based versus what's the actual benefit of that stitching together of the rotator cuff tear. So that will have profound implications for how we manage people with rotator cuff tears.
That's amazing. And I'm excited for that. But then I also just had the thought, like, how is that not the first step?
Yeah, well, mate, we can get philosophically inclined with that question as well. Like, do we start with placebo controlled trials, or do we start with, so that's an efficacy question where we compare a treatment with a placebo, really common in pharmacological treatment, very uncommon in orthopedics and musculoskeletal condition. And I'm kind of okay with that not being the first step, because otherwise we would have no treatments for anything, right? Because we would have, because we're maybe meniscal tears have been compared to placebo surgery in the knee and in the shoulder. I've got a couple of trials. We've got a couple of trials in other non-musculoskeletal conditions, but we really don't have much else. So we would just have no treatments if that was our starting point. And so I'm okay with starting with effectiveness, comparing a surgery with usual care, and then, eventually looking at efficacy, which is comparing to a placebo sham intervention. But it's a conversation that is it ethically dubious to give someone a fake surgery? There's a rich literature devoted to that question, and the answer is that it is. It's ethically okay. Um, people. Arguably, it's more unethical to give someone a surgery that isn't proven to be superior to placebo than give someone a placebo surgery, which probably has less side effects than an actual surgery.
Hmm.
So yeah, there's a you can get really philosophical with that question, but I think it is important over time that we start to conduct these placebo-controlled trials to actually figure out what is the actual benefit and what is the contributing components to a particular outcome. Is it specific effects of the surgery, or is it the non-specific effects associated with the ceremony of the surgery? Because if it's predominantly the non-specific and contextual effects associated with the surgery, we have to have really robust and honest conversations about whether we should be offering this expensive placebo. Now, we also have to have the same conversation about our treatments, which have not been shown to be much superior at all, actually, to placebo as well. So I love to, call out surgeons as well, and we should, because it's more expensive and there's more side effects and so on and so forth. But, we are in a glass house when it comes to that as well. So we've got to call out our own practice equally.
I love it. You're always making sure that the pendulum doesn't swing too far in either direction. And again, what I was saying earlier about making sure that the boat is going in the right direction.
Yeah, we've all got to be held to the same standard, and exercise doesn't get held to the same standard as other conditions because it's this good, right? It's this global good. It's exercise. It's like a healthy diet. It's getting 8 hours of sleep. It's just got to be good for you, so everybody should do it. And I am really sympathetic to that viewpoint, but we do have to police it and scrutinize it and interrogate it and hold it to the same standard as we love to hold other things too, because most people are coming to us for pain relief. And so we can say, look, it's going to decrease your blood pressure and it's going to improve your metabolic health and all this stuff. But is it really, when they're doing 3 sets of 10 of an exercise for 3 weeks and then their pain goes down and then they stop it? Is it really going to increase all these secondary benefits? Probably not.
Yeah, fair enough. And again, that's what you're doing now, right? You're the one who's really scrutinizing it and taking a very honest look at how effective it is. Jared, I'm cognizant of the fact that we're almost out of time, but is there anything that you want to share that maybe you're frustrated about and hoping that will change, or anything that you're just generally hopeful of in physiotherapy? Anything exciting going on?
I'm an optimist, Noah. So it sounds like I'm negative and critical and this and that, but I'm an optimist. I think physiotherapy is an amazing profession. I think we have a really important role to play in society. I think that what we can provide in terms of education, reassurance, advice, and movement-based rehabilitation is powerful. I think it's cost effective. I think it's a really important role for that we play in society. So I'm a huge proponent of physiotherapy and exercise-based treatment. However, we've got a ton of stuff that we need to iron out in terms of research, and that's slowly being done. In the shoulder, we are reliant on a lot of very poor, low-quality clinical trials that we seem to run with and then extrapolate and overestimate the benefits of those particular trials. The evidence base is slowly getting a little bit better, which is promising. Exercise is really poorly reported in the literature. So when you actually see a randomized control trial being done, those people very rarely who are doing that trial actually report the exercise program that they delivered. They don't report the explanation that they provided in conjunction with the exercise program. They barely report the adherence. They certainly don't report the parameters of the exercise program. Imagine a pharmacological study being published and then saying the dosage or the milligrams of the medication under study and not reporting it. It's it's
Yeah.
really poor when you look at it. And we have a study coming out on that very topic. The reporting of exercise is horrific, and that precludes really strong conclusions being drawn from the literature, because we actually don't really know this active ingredient under testing. So that's a problem. But we're going to get better at it over time. We are in our infancy. So evidence-based medicine is like 20 to 30 years old. It's young. Physiotherapy is sort of really at the start of applying evidence-based medicine and evidence-based practice to our treatments. So I really think we're gonna go a long way over the next 20 to 30 years with a lot more high quality research under our belt. So I think I'm generally optimistic, Noah. I think physios is here to stay. I think it's probably going to have more of a prominent role going forward in terms of the management of non-traumatic conditions. I'm not worried about AI taking over physiotherapy in the short or medium term. Perhaps in the long term, it'll take over everyone. But I think over the next half a century, we're good to go. So don't worry too much. I think people are always going to want the advice and input of another human being, and particularly who's an expert, hopefully, and the reassurance from that person, and maybe just some good active listening, maybe some manual therapy if you're so inclined, but certainly some like movement-based rehab to help that person's pain out. I think humans have been wanting that for millennia, and for the foreseeable future, I think we're going to be wanting it as well.
Well, I've never perceived you to be sort of negative. I've always perceived you to be practical. And again, I sound like a broken record, but someone who really helps to push the profession forward in a really meaningful way. So I think your criticisms, I don't take them in a negative way. I take them in a very, very important and essential way. So Jared, thank you so much for coming on today. I really, really enjoyed chatting with you, and I learned a lot. And I think a lot of people, especially those who have not come across you before, will be, enriched with everything that you shared with them today. So just wrapping up, where can people find you? Where can they follow you? What's the best place for them to learn from you?
Thanks, Noah. Yeah, it's been fun today. My website is shoulderphysio.com. Really easy. I am on Instagram at shoulder_physio, I think. And occasionally on Twitter, Jared Powell 12. And my podcast, Shoulder Physio podcast, easy. It's I'm everywhere. Any one of those mediums, you'll find a bunch of good content.
Yeah, I agree. They're all great places to follow you, and I've been an avid listener of the podcast for a few years now, and it's really, really worth the listen. So at risk of hurting my own ratings, I think you guys should check out Jared's podcast.
Thanks, mate.
All right, Jared. Well, enjoy the rest of your day. I'm going to get ready for bed here on my end.
Cheers, mate. Nice to chat.
Cheers. Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.